public health, and not just in law.
Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care. Today, we're talking to Dr. Lauren Hughes, family physician, executive, and health policy leader about physician as patient, navigating medical emergencies. Let's get started.
Hi, good afternoon.
Hello, Dr. Hughes. Welcome to the show.
Thank you so much. I appreciate you having me, and I appreciate your understanding with having to reschedule when I wasn't feeling well before.
Everyone's so busy. I feel like these days between our work lives and like family life and it's the holidays.
And travel and the news and everything else. Yeah.
Yeah. And that's how actually we initially found you actually was from the news, which was amazing.
Well, you're right. I mean, we had met at the PCFA meeting in Washington, D.C. And one morning I was just flipping through the Washington Post app and I'm like, wow, I know her. And we generally work in healthcare on the dull end, all of us, right? Not the blunt end. We don't work on the sharp end. And when we come in contact with the sharp end, it's a real wake up for a lot of us and about the importance of that work on the blunt end, right?
A huge wake up call. And as I've been sharing with colleagues recently, before my accident on February 4th, I knew that our so-called healthcare system, was broken from a clinical perspective, helping patients navigate the system, and from a policy perspective, so more from a theoretical perspective with the work that I currently do. And now I know it on a very deeply personal level. I'm not entirely certain what I am going to do with all of that yet. And no one asks to be an accident, clearly. And I'm someone that can see a whole wide range of potential policy opportunities that come out of something like this. And it's a matter of, letting the dust settle. 2025 has been a long year, and looking forward to the next year and exploring ways to build upon my experience and use my voice as both a patient and a physician who happens to also do policy research and work to shed some light on some of the challenges that my experience brought to light. So I look forward to next year. We'll see what happens.
Right. But because you helped build the NASM report on implementing high quality primary care, if I'm correct?
Wasn't part of the committee that developed it. However, okay. I co-chair alongside Dr. Mary Wakefield, the Standing Committee on Primary Care. And so we are fulfilling the accountability sort of objective within that report. And we are a group of 21 primary care research policy, clinical, patient experts that advise the federal government and other entities on a wide range of primary care policy issues. And so we certainly use that 21 report as our foundation for the work that we do. But certainly, that report came out now 4.5 years ago. So if there is new evidence or information that is an update compared to what was published in 21, we certainly comment on that. But yes, very, very busy on that level within the national academies and advising on primary care policy.
Yeah, Dr. Hughes, so many of our listeners are really geeky about primary care. They're really geeky about all the issues in our current system and all the frustrations. And before we get into talking about like the system and all systems and policy and all, I'd love for you to share your story for those people who haven't heard it. Just walk us through what happened after your car accident, especially for the residents and mostly medical students and residents, because a lot of times they're just in it. Remember, in residency, I remember when I finished residency, I didn't even know how to bill. I remember I was putting 99213s for everything at my community health center. But if you could just walk through that for the younger doctors, especially, how you navigated through all of that, the hospital insurance, the billing, all of that.
Absolutely. And I will do my best not to take 30 minutes to tell the story. So on February 4th, Tuesday morning, I know that and remember that because Tuesdays are my clinic days in the context of my current role at University of Colorado. I was driving to clinic. I was almost about, within a mile and a half from from arriving at work. And I do my clinical work at a rural, federally qualified health center north of Denver in a town called Fort Lupton. And I am driving north on 85, which is a divided highway. Speed limit is 65. It's not an interstate, but traffic moves along pretty quickly. And I was listening to a really good audiobook. And I remember thinking, I want to finish this chapter before I pull into the parking lot. And I'm listening. And then the next thing I know, I'm on the side of the road. I hear, crunch. I hear glass. I hear all those things you'd hear about in an accident. And I'm on the side of the road. And my next thought was, are these my airbags? I never saw her coming. And it was a young mother, 20-year-old. She was trying to get to work. I was trying to get to work. She had her infant son, fortunately, appropriately strapped in the back seat of a Ford F-150 pickup truck. And she failed to yield properly and T-boned the front of my Forester. Very grateful that she wasn't 6 inches to a foot and a half off. I might not be sitting here. And that is just the fact, of the matter. And after my car came to a stop on the side of the road, I was, physically struggling to breathe because I had just been hit by airbags. And I took a couple seconds to try to catch my breath. I was able to unbuckle myself and self-extricate from the vehicle. And my clinical mind was already taking over, like, oh, this is a good thing, right? Like, I can get out of the car. I was able to walk 3 steps. And then my doctor brain continues to kick in. And I realized, oh, across the way in the ditch is obviously the person who hit me. And I don't see anybody getting out of that vehicle. I better go check on them. So I took a few more steps and all of a sudden I got very dizzy. And then I said, okay, whoa, you were just in a car accident. You don't have to go check on that other person. Why don't you just sit down and rest? So I took a few steps back and sat on the edge of my car seat. And I didn't know this. This is a pro for technology. I had set up crash detection with my iPhone. My iPhone was the one that had alerted EMS services because it flew so quickly in the accident. I don't know where it went in my car, but because I didn't turn it off and say, no, I don't need 911, I'm convinced that it brought police and fire to the scene of the accident much sooner than it otherwise would have. And so, they came and they assessed and they started both doing the investigation and of what happened and, checking on all of the 3 of us that were in the accident clinically. And, they asked me, do you want to be seen in the hospital? And I said, absolutely. I said, I could tell, adrenaline was pumping, but I could tell something was wrong with my right leg. And my right ankle was already swelling up quite a bit. I said, I need to be evaluated, period. And so all 3 of us ended up in the same ambulance, which I do think made so that my ambulance bill wasn't as expensive. I would need to verify that, but I do think that's what happened because my ambulance bill was a lot less than what I was expecting it to be. Got transported to the nearest hospital, Platte Valley Medical Center, which is out of network with my Anthem insurance through my employer, University of Colorado. And that's an important fact in my story. And I got taken care of, excellent care at Platte Valley, got all the usual trauma workups in the emergency department. And, after the accident, I'm doing all the things one does after you've been in something like this. I'm talking to my boss and letting my team know I won't make the meeting that afternoon and arranging care for my pet and talking to my family and, putting all these things in order. And as a clinician, understanding from my team taking care of me, this is what I'm being diagnosed with. This is what's, needs to happen. In my mind, I'm like, yes, that checks out. Okay, great. Obviously, and I knew at that point that I had a broken ankle and that I had a massive knee wound from hitting the dashboard that needed to go to the OR to be washed out and to be sewn back together. And so I was looking at, practically speaking, an overnight stay in the hospital because I was going to be an add-on case that day. So I knew it was going to be later in the day. I got admitted, got to the floor, got all the work up, and was just sort of in holding mode until I, got surgery. Came out of anesthesia at around 9:30 that night and stayed overnight, and then went home the next day midday with a friend of mine because I was not in a place to drive. I couldn't drive, and my car was totaled, so I had to have someone come and take me home, and then began my recovery of 6 weeks using a walker, not being able to bear weight on the right leg, having a knee in that right leg and an immobilizer, and so on and so forth. And really, since June, July of this year, physically, I have felt great. I have felt as I did before the accident, and for that, I'm very grateful on a number of levels. Now, relative to my challenges with billing and medical necessity and No Surprises Act, that really began 4 days after I got home from the hospital. A pro tip that I will pass along is if you are home on a Saturday night recovering from an accident and you get an email from your health insurance company, don't open it. Not a good time to open an email. I did, and it was my explanation of benefits from Anthem, letting me know that my claim for my services in the hospital were going to be denied because they were not medically necessary.
Oh, God.
It's 10:30 p.m. on a Saturday night, and oh man, I was probably the closest I got to levitating that I ever have. And so began my journey in trying to figure all this out and to dig into what happened, where there were administrative issues that caused billing issues, and where the No Surprises Act did and did not apply in my case with the fact pattern and the sequence of events, and ultimately what I had to do to navigate to get it all resolved.
What were you thinking in that moment, though? I mean, like, we never use, most of us hardly ever use insurance. Maybe there's like a pre-authorization thing or something. I mean, we don't ever think about, we don't even think about insurance to go to the doctor. We think about, okay, I've got, insurance for the hospital. Or have you ever been in a situation like this before? Like, did you?
Never.
I mean, this is probably the first time you had to use insurance, right? You probably didn't even have to think about it.
First time for an accident, first time for an ambulance ride, first time for surgery, an overnight hospital stay, first time on, strong pain medications. I mean, this was a first time ever doing physical therapy. I had a lot of firsts in this particular situation.
So nothing in the hospital, like there wasn't nothing medically happened that wasn't, everything that was supposed to happen medically happened properly, right?
Everything medically. I really did receive excellent care while I was there, and everything went according to plan. I did very well. I was stable overnight, didn't have any issues, clinically. Vital signs were stable, wasn't overly nauseous or sick to my stomach in any way.
Anesthesia was okay. You were fine.
Anesthesia was okay. I mean, everything kind of went like clockwork in the hospital. Behind the scenes, there were errors that made things ultimately not go like clockwork. But my experience as a patient, from the time I arrived via EMS, I was assessed and stabilized and then told that I needed to have, an ankle surgery and a knee washout, and that likely I was going to be staying overnight. In my mind, I'm like, okay, great. I was not thinking at that point, well, maybe I should call my insurance to see if this, to get any approvals that I needed, or I wasn't thinking, well, maybe I should ask Platte Valley, my admitting team, at what level of care are you admitting me? None of that. I was a patient first in this, situation. And even though I did receive that feedback later when I did engage the incredible team at Kaiser Health News, the Bill of the Month series, Julie Appleby, who is the reporter that I worked with, who was excellent in her investigative work. When she reached out to Anthem and the spokesperson there, that was the advice that she told Julie. Well, she should have, asked these questions. That's impractical from my perspective.
Oh my gosh.
Again, like I mentioned earlier, I'm trying to arrange care for, my pet and talk to my family and my boss and, in understanding what had just happened to me and what was going to be my care plan. The last thing I had in my mind, especially even as a physician who does policy work, was let me ask about the level of care I'm going to be admitted under. Not even close.
Okay, you've just been through this accident. You've been through an emergency situation. you've got a broken ankle, you've got injuries. I mean, you're going for surgery, and the expectation is, okay, you're in the ER dealing with all this, and you're supposed to stop and speak with somebody to see, hey, is this covered by my insurance? Or you're supposed to call your insurance company and be like, hey, I was in an accident, I'm at this hospital. And if anybody would have said no, is the expectation that you're supposed to just leave then, or be transferred to another facility? I mean, what is the logic?
These are all great questions. And when you think about practically what you're navigating in that moment, when you have been in a traumatic car accident, and also sort of grappling with bigger picture questions like, oh, that was a close one.
Exactly.
Right?
Like a life and death situation.
That's not, it's so when I heard that suggestion via the reporter I worked with, I honestly had to roll my eyes and shake my head, because it just isn't practical. And when you are in a moment like that where you're very stressed and thinking about, if you had taken those steps and made those phone calls, what would you have realistically done with that information? My car has been totaled. It's now being taken away to a junkyard. I don't have, any other passengers or friends or family immediately available to take me to an in-network facility if that were what I had been told I needed to have done. And so it doesn't practically make any sense for the patient experiencing this traumatic moment.
God, I mean, it's like, the world looks at America everywhere outside, like, we've got just amazing medicine. Our hospitals are these beautiful hospitals. And then here, a doctor who designs this policy and the system, like, witness the failure of the system. Like, medicine is good. Like, medicine is great, but like the system that wraps around this beautiful thing that everybody in the world is amazed with is failed.
It absolutely did. And when you think about our so-called healthcare system, the fragmentation and the very complex and convoluted layers of billing and administrative errors and coverage policies and state laws and federal laws, there are oodles of opportunities for things to go wrong. And they did in my case.
I mean, but can you imagine for a resident right now listening? Okay, you've got a trauma patient that came in. I mean, what we think is medically necessary, or remember as an intern or when we're on trauma or whatever. Yeah, we're family doctors, Dr. Dan, but I train an opposed family medicine program. We had traumas and stuff like. I mean, there's what's medically necessary, and then there's this.
Well, and I mean, and if I'm not mistaken, part of what happened in your situation was they said that the admission wasn't medically necessary because nothing bad happened, but wasn't that the purpose of the admission, to keep anything bad from happening after the surgery? I mean, it was, but because the surgery went well, you didn't qualify for admission, but one of the reasons the surgery went well is they kept you around long enough to make sure it went well. So
it went well. Yes, it's sort of a little bit of a vicious circle there. And
right.
let me break this down a little bit, because your question, Dr. Dan, is getting to the crux of the matter and the facts and the sequence of events that applied in my particular case. And it really centers around sort of administrative and billing issues, and then medical necessity issues. And with the administrative and billing matters, again, as a reminder, my insurance has emergency coverage provisions, right? Like many plans do. Platte Valley is out of network with my plan. So in routine usual care, I would never have gone there because it's not in network, clearly. However, in this particular situation, it was a bit of a contractual stipulation that Anthem, my insurance plan, and there is an agreement in these kinds of emergency situations, but the quirk is that all services before and after admission are approved or denied together in a bundle. And in this case, because my ankle surgery and the knee, surgical washout and repair were bundled together with the inpatient level of care as it was initially billed by the hospital, the entire claim, around $64,000, was denied. So it was the enmeshment of these issues. And what happened, and I'm not sure where in the process this happened, it probably was somewhere in that intake when I, was, taken out of the ambulance, put in a wheelchair, wheeled into the emergency department, into the trauma bay, and started the workup. And you've got people coming in to get your blood. You got people coming in to give you medications. You got people coming in to say, we're going to go take you over here and do a CT scan. Then you've got the administrative billing people coming in. They're wheeling in their little computers and their carts, and they're, having you sign all this paperwork. I also had police there that the policeman was asking me questions about how fast I was driving and what happened and what I recalled. So there's like multiple people talking and addressing you for multiple purposes in the room. So somewhere in there, I may have said, this is my insurance. Please give me my wallet. I'll give you my insurance card. And you handed them the insurance card. And what didn't happen is that my particular plan with Anthem was not properly flagged in the internal systems within Plant Valley. So there's some box that probably was not checked in their system that would have alerted them to say and to know, oh, we have to disaggregate the surgical services from the level of care, or it would have triggered them to say, we need to talk to Anthem to get approval to proceed, or whatever the process would have been. Because that wasn't done administratively and correctly internally in their systems, it led to my entire, the surgery and all the additional sort of inpatient services being bundled together. And that was what kept getting denied from Anthem multiple times. Plant Valley tried to resubmit the claim, and Anthem was saying, no, this is not, and this is where you get into the medical necessity determinations. And so, I mentioned 4 days after I came home from my accident on a Saturday night, I read my EOB and says it's not medically necessary. In that moment, I reacted as a patient and as a human. And I read that as, what do you mean? What, I was supposed to leave with a broken ankle and not get my ankle fixed?
Exactly.
That's not what they meant. They clearly, yes, I have a broken ankle. I need to have it fixed. The procedure is medically necessary. What Anthem was saying wasn't medically necessary was my inpatient level of care. Because in many cases, and this is, this makes sense clinically, that my, an ankle procedure can be done safely in most cases at an outpatient level of care. And mine was being done in the context of an inpatient level of care or an admission in that case. And so you're right, Dr. Dan, Anthem was saying, look, she wasn't complex enough or unstable enough medically for this to be a slam dunk inpatient admission, because I was very fortunately, very stable, before, after, during my surgery. And for the first few weeks and months, I was trying to navigate the medical side of this after a car accident. There's the property piece, there's a liability piece, and then there's the medical health insurance piece. And today we're mostly focusing on that third bucket. And as I was trying to navigate and figure out how to respond medically and get this massive bill paid, I was thinking initially, well, this has to fall under the No Surprises Act, right?
Right.
Like there's billing protections for me and to protect consumers in this very instance when you are taken to an out-of-network facility, that at a high level, conceptually, your bill should be covered at as if you were being cared for at an inpatient facility at those rates. What I have subsequently learned is that the No Surprises Act does not necessarily sort of obviate the medical necessity determinations or the power that insurance companies have. And so No Surprises Act doesn't necessarily override that, and medical necessity determinations can take precedence. And so throughout the spring, summer, and early fall, there were many things I was trying to do to get this resolved. Dozens of calls to the billing department at Platte Valley, dozens more calls to Anthem to try to get this figured out, and to ask them very specific questions about which criteria are you using to make medical necessity determinations. Can you send me a copy? You call, you wouldn't get it. You'd have to call back and say, I called you on this date and time. I didn't hear back. I'm calling back. So a lot of follow-up. So, a lot of time spent in those types of calls. After a certain point, when Platte Valley was saying, hey, our bill is not getting paid, they then move the bill internally in their system from the billing department to another department, the payment department that works on setting up payment plans with consumers. So I was getting calls twice a week from a different department within Intermountain Health, of which Platte Valley is a part, saying it's time to set up a payment plan for the nearly $60,000 that you owe. My medical payments with my car insurance paid about, I don't know, up to $5,000 of the bill. And then the rest was internally because they had tried to bill this multiple times to insurance. And Anthem kept denying it, saying it wasn't medically necessary. They moved it from the insurance bucket to the patient responsibility bucket, and hence coming to me to say we need to set up a payment plan. And I'm like, this still does not make any sense. And then you kept getting these final bills coming in the mail, now like with red lettering all over the bill. And ultimately, my bill, not for very long, but my bill did end up going to collections, and I had to pull it back from collections. So that's what my spring, summer, and fall was. And ultimately, in the midst of this, late July, I submitted a first level appeal to Anthem, which was denied. I ended up working my way up to the top brass human resources professionals for the entire University of Colorado system, not the School of Medicine and the medical campus where I primarily work. They were fantastic. So, and one thing I learned, important to engage and involve HR professionals, especially if you are like half of Americans that have insurance through an employer. Leverage those resources because they may have connections with these different insurance plans that can help get you unstuck in these moments. And then really what accelerated the resolution of my situation was having the good fortune to have my story selected by Kaiser Health News, Bill of the Month series, and to be featured in October. And when you get reporters and media involved, it's amazing how quickly things just, the pace kind of picks up in terms of getting your issues resolved. And I am phenomenally grateful to that experience and that exposure. And along the way, personally and professionally, wearing multiple hats, I sort of decided that, let my story and my experience be another data point in a sea of data points that our system is not working for a lot of people. And so I'm very grateful that I was selected for that particular feature. And once I got media involved, ultimately, it really sped things up. And on October 3rd, Platte Valley resubmitted my bill after they had another round of peer-to-peer conversations with Anthem, downgraded the level of care from an inpatient level of care. It got submitted. And what is mind-boggling to me, just from a practical standpoint, is that the original bill was around $64,000. They downgraded the level of care, resubmitted it at $61,000, a difference of $3,000. Unbelievable. Although now it is believable to me after going through this experience. And Anthem did pay about $21K. The rest was contractually written off. And so it got resolved and it got pulled back from collections. It got pulled back from, the billing staff at Platte Valley said, this is, no payment. So let's pull it back and please stop calling her because we're working with Anthem now to get this figured out. So it has been a journey.
So insurance company ended up paying $21,000.
Correct.
So when this went to collections, what was the number that they put on the collections for you?
The collections would have been it was close to $60K that was sent to collections because that was the outstanding bill, less what medical payments for my car insurance paid. And that was what went to collections. It was only in collections for maximum a week or so.
Did this hit your credit report?
I watched very closely. It did not.
Oh, thank God.
That was top of mind for me. And Colorado has additional state level protections for this very issue when it comes to medical debt and whether that can or cannot be reported to credit agencies. But that was something in the midst of all this that from a personal and professional, a moral perspective, there was something wrong here administratively in the chain of all the events that happened. And so I was not inclined to pay $5 of this bill. And also closely, very watching, make sure that it didn't, I was like, please don't send us to collections. And I asked them, and I said, I'm working actively, I'm appealing this, I'm working actively to resolve this. Please don't send it to collections. And, these are often very automatic processes behind the scenes. And it went there. But on October 3rd, I had a conversation with a senior customer relations professional at Platte Valley that said, we are doing 3 things today. Number 1, we are resubmitting the bill at a downgraded level of care to Anthem. Number 2, I have issued, a stop bill on your account, meaning that I was no longer, as of October 3rd, going to get calls twice a week from Platte Valley saying it's time to set up a payment plan for the $60,000 that you owe. And number 3, she'd had a conversation with a medical debt vendor that this was not in collections. And so that particular phone call, things weren't entirely resolved at that point, but I felt like I had lost 50 pounds, huge weight off my shoulders, because we finally had broken the logjam of trying to move this forward and get this resolved.
I feel like with residents, they're not going to think about the cost, in an emergency situation, they're just going to do what they are trained to do, and they're inheriting
Absolutely.
this. They're coming into this mess. I know the world has changed so much in the last 20 years, right? I can imagine now with all the information being readily available, you don't have to go to a CME conference. People are just finding out these things so quickly, right? Before we go to a conference and they're inheriting this. I can imagine okay, what can we do to fix this?
Yes. So many, many thoughts on that. I will say first, with my patient hat on, if you are in an emergency, please get the care that you need. Get stabilized, get cared for, get your broken ankle fixed, whatever it is. And later on in the conversation, I can share some pieces of advice, insight that I have now based on the situation that would really apply after the fact. I mentioned earlier in our conversation that officials and spokespeople at Anthem said, well, she could have called and made sure that it was okay to be admitted, or asked her team at the hospital at what level of care that is she going to be admitted under. I disregard that advice. It is not practical in the moment when you are stressed, when you're injured, and you are trying to get taken care of. But when we get to that point in the conversation, I do have some, practical tips for how to navigate more effectively the situation after the fact. Being a physician in this situation did not necessarily give me magical knowledge of how to navigate the situation as a patient. However, when I sat down and made the list of resources and connections that I have as a physician, or that I knew about from my policy work, it is an embarrassingly rich list. And what makes me so angry in this situation is when I think about the patients I care for in a rural, fairly qualified health center, they wouldn't have anywhere close to this. And that is unjust, and it is unacceptable, period. And some of those resources I had available to me were, 1, a friend's husband who happens to be a personal injury lawyer. I hired him to help manage that aspect of my accident aftermath. Another colleague in the health policy center where I work, who in his previous life was an insurance lawyer. He helped me rewrite my first level appeal letter to Anthem. I serve on a committee within our division of insurance in this state. And the type of plan I have is a government non-ERISA plan, meaning that it would fall under the auspices of state jurisdiction when it comes to, regulatory authority and oversight. So if I had needed to file a complaint with a division of insurance, I could have. I had connections to senior level HR professionals, and I knew about things like bill of the month. I had all these resources, and it was still a challenge to navigate. And so that gives me a lot of opportunities for pause for thought and reflection. Back to your question specifically, what are some changes that we can make from a policy perspective and to protect patients from financial harm, even in situations where you are insured like I was and I still am. And I'll go back to the No Surprises Act. Even though it ultimately didn't play a significant role in my particular case with the facts and the sequence of events, this is an important law that I anticipate needs to be and should be revised over time, particularly as we gather more and more evidence and insight through case law. This is a young law. It was passed in 2022. So it's only been around for 3.5 years. What I think we need to fix and shed more light on is the challenging intersection that happened in my case. Who's on first base, who's on second when it comes to medical necessity determinations versus No Surprising Act billing protections, right? And so what is the relationship between medical necessity determinations and the provisions of the No Surprises Act? And so that merits a lot more attention and clarity as we move forward. Relative to the No Surprises Act, as I have dug into this after the fact, there are a lot of loopholes and issues that need to be addressed. There are protections against air ambulance surprise billing in the No Surprises Act, but not for ground ambulance transport. When you think about ground ambulance services, it's a very heterogeneous policy environment in terms of who owns them and how they're operated and how they're financed and public versus private and, on and on and on. And so No Surprises Act needs to be modified to address those surprise billing issues in my opinion. The second is that there needs to be stronger network provider oversight when it comes to expanding in-network providers. So if you are in an emergency situation being cared for, we need to have greater oversight and clarity around who is considered in network so that you aren't caught in this situation of being cared for by an out-of-network provider. So we need to have stronger sort of oversight in that regard. And lastly, another loophole that needs to be fixed with the No Surprises Act that I could have fallen subject to, but I didn't, is this notion of a notice of consent loophole for post-stabilization care. So I come in, ambulance to the hospital, I'm in the emergency department, trauma bay, I'm getting stabilized, right, in the emergency department. And then we have a plan of action, like this is what needs to happen clinically. And at that point, and it's not often always clear when you pass as a patient, when you cross that threshold into a post-stabilization period, right? But there can be, if you are getting care at an out-of-network facility, there can be a moment where they say, okay, in our medical opinion, you are stable enough to be transported via non-emergency transport to an in-network facility. And then you had that conversation, you sign forms and you leave and you go to another place to get that care. The flip side of that is that they can present you with a consent form that says you can stay at this facility to continue to get your care here. But in signing that form, you may be giving up your rights for No Surprises Act billing protections, which leads to them being able to balance bill you down the road. I could have been subject to that given the type of care and the facts of my case. I was not. I do not recall being told you are medically stable and can go to an in-network facility. And I was not presented with such a consent form, but I was in a situation where I could easily have been presented with that. And addressing that particular loophole is another aspect of No Surprises Act that needs some attention from a federal policy level.
And I can imagine the providers in that situation. I mean, then that gets into the EMTALA part of care, is when is it medically appropriate to allow somebody to be transported? And I know spending most of my time around a large academic medical center, what the general guidance we were always given was you could only transport somebody if you were transporting them someplace that they could get care that they couldn't receive at your facility, as far as paying for that transportation. And again, you're talking about in your situation, I'm assuming because you didn't have a car. So if somebody had decided to transport you, you were likely going to have to get in an ambulance, and yet
Correct.
who's
Or
going to pay for it?
phone a friend or
Right.
something. And I'm also, right-handed, and and everything was broken on the right leg. So it would have been difficult for me to have driven myself personally if I had had a car to get to where I need to. But, you bring up a really great point around, there's lots of overlapping Venn diagrams here, right? When you think about the immense power that insurance companies have over medical necessity determinations. And then you think about the provisions of the No Surprises Act, and then you think about EMTALA. And, where does one end or the other one begin, and this, that, and the other. And it can be so exceedingly difficult and mind-numbing to try to tease this apart. And, taking a step back and thinking about a different policy matter entirely. There's often those of us that are adjacent to Medicaid or do Medicaid work, we often say, well, you've seen one Medicaid program, you've seen one Medicaid program.
That's right.
And it struck me as I've been processing, what's happened this year is that my experience of being taken by ambulance to an out-of-network facility, exceedingly common experience. A lot of those experiences led to the creation of the No Surprises Act. But similar to that logic of one Medicaid program, if you've seen one, you've seen one. It's like if you have experienced the confusing, convoluted billing and insurance and issues that get enmeshed with state and federal law, you've seen one of those examples, because so much of this depends on what happened, in what order, what conversations did you have, what forms did you sign, does your insurance cover you or not? And so it's a matter of kind of breaking down the fact pattern and the sequence of events that makes it so that even though my overall experience as a patient was exceedingly common, the way things happen and the order in which they happened might be quite unique and an experience unto itself.
We talk about it so much that we're the only developed country in the world where medical debt is the number one cause of bankruptcy. And for someone like you or many of us who have resources, we have good insurance, we have friends and all this,
Absolutely.
like we can figure out a way, right? I work at City Block Health. We deal almost entirely with Medicaid. I mean, I can't even imagine what our population of patients would go through. Crazy thing is, we wanted to talk with you about all this policy stuff, but now you got us back. I mean, I'm just rethinking what medically necessary. Well, first of all, you're going to have to come back. You're going to have to come back because we have to talk to you about value-based care and primary care and resident
rural health, all the other
things. I have
things.
to talk about all the fun things. There's so much fun stuff happening, but this has turned into something completely different. I mean, even right now, I don't think if you're at any major hospital system, I cannot imagine if the hospital can treat you there, why anyone would agree to transfer you somewhere else.
Mm-hmm.
I just can't. I know that's what's supposed to happen, but I cannot imagine that happening. Like an emergency room doctor even agreeing to that.
It doesn't practically make sense when you think about the clinical workflow and experience, right? From pre-hospital care to being seen in the emergency department and making your plan. And at that point, you just want to be taken care of. You want to get the broken bone fixed. And so it's where the rubber meets the road, right? Like understandable, good intentions behind policy design, and then how that actually plays out on the ground. And I do want to go back to what you were saying around medical debt. And the reality is that as a physician, if I had to owe $60,000 over time, I could have figured that out. I didn't have that just sitting around ready to pay that. And the anxiety and stress and sleepless nights that came along with this experience, this year, it worried me a great deal. And I also knew fundamentally that I was going to get this figured out, right? Because there were errors here. If I owe somebody $60,000 and it's legitimate, And it is defensible,
A
and it's
couple
laid out.
Subaru Foresters.
Yeah, exactly. Then I owe
Not
you that
one. Let's
money.
get two of them.
Let's get two, right? Like
Let's
I
do a
owe you
6-year
that money.
payment.
Yeah, right. But in this case, I'm like, no, there were errors here, and let's figure these out. And I think of big picture thoughts is, our health insurance companies expect and bank on you not speaking up and not fighting back. I didn't do that. And there are moments in this past year where it really hits you that when you have insurance for it to be there and to take care of you when you need it, when you least expect it, when you've been T-boned on your drive to work, right? And the amount of fight and tussle to make this right. And you realize along that way that, the motivation is not to pay these bills. And it is really challenging to think through that is when they should be stepping up and taking care of you after you've had something happen to you like this. And, at the end of the day, my experience with our so-called, healthcare system, at times it has felt disjointed, disrespectful, dismissive. And this is not a red issue, a blue issue, or anywhere else you might find yourself on the political spectrum, right? Having this kind of experience with our so-called healthcare system has become a uniquely American experience, and it is unacceptable. We can and should do better, period. Back to what I was saying at the beginning, to know how fundamentally broken our system is at a deeply personal level, not sure what I'm going to do with this yet, but my experience highlights oodles of policy opportunities to make things better.
It's like, we've got the greatest medical system in the world, and like the most corrupt healthcare delivery system that profits when they don't pay bills, right? And like there was a celebration. There was somebody who was like, "Hey, we just denied this thing. It's a $60,000. We didn't have to deal with it." No.
I don't know that happened, but I would say that we do. It's not. I have heard people say, I think, wasn't it Wayne Jonas said, we don't really have a healthcare system. We have a sick care system. We don't pay to get people healthy. We pay for all the things we do to sick people. And I think that's part of the advantages of encouraging more primary care to work on how we keep people healthy, because this happened in a car accident and there wasn't a whole lot you could do to prevent that. But there are a lot of similar things when people have heart attacks and strokes, that if they had access to good primary care to manage their chronic conditions, it would decrease the risk that they would have this same type thing happen. Because if you had been at the mall and had a heart attack, the same thing would have happened, right? They would have taken you to the out-of-network hospital.
Absolutely.
And you would have been dealing with it. So, and if you could have prevented that, it would have been pretty cool. So I know we've been spending a fair amount of time. You did say that you had some tips if one of our listeners wound up on their back in an emergency room with somebody handing them a clipboard. What's your advice to doing?
Well, certainly if you are, I was not handed that notice and consent form on a clipboard. I was handed other pieces of paper on a clipboard, certainly, or a digital version of said clipboard. Absolutely make sure that anything you're presented in the moment in the emergency department, you are reading carefully and closely. You're asking for additional support and assistance to really understand what the implications are of what you are signing. Again, in any kind of traumatic or emergency situation, please take care of yourself and get the care that you need first and foremost. And then after the fact, right? Starting 4 days after my accident, when I got that your care is not medically necessary determination from Anthem, I wish I would have sooner dug into the details much more quickly and ask questions like, how are you making your determination? I would like to see these guidelines. Have you done peer to peer, right? Who are you talking with, right? I would have asked a lot more questions along those lines. And I would have asked them as well, like, please point to me in my contract with you what you are saying. How is it backed up in my insurance plan or contract? Like, I'd like to see it with my own eyes. Document, document, document. Every call, date, time, how long you're on the phone, what they said. It is painful in the moment, and it is very helpful as you proceed through something like this to have all of that information, at your fingertips. I discovered along the way that in my various conversations with billing professionals at the hospital, that I was receiving conflicting information. And I give people the benefit of the doubt. I don't think they were doing that on purpose. They were doing their best to help me with my questions in the moment. And as someone who does a lot of analytic work for a living, I should have stepped back and said, why am I getting conflicting information? And use that as a trigger or a leverage to escalate my case much sooner than what I did. Like, I need to speak to your manager, please. I need to speak to the head of, your billing department, or who is in customer, relations that I could speak to, and please get me to those individuals. And I certainly would have, looking back, given the type of insurance plan that I have, HR was incredibly, incredibly valuable. When I got to them finally, it wasn't until late August, early September, and because I was trying to figure this out on my own. And I submitted my first level appeal to Anthem at the end of July, and they were somewhat stunned that I had taken those kinds of steps. They're like, we were here to help you and support you. And good to know for others going through something similar, that is a great resource to go to sooner than what I did in my case. And it may have, if I had gone to HR, say, late spring, early summer, it may have obviated the need that I felt to submit my first level, appeal to Anthem. And so those are some tips that I would pass along from the trenches.
Dr. Hughes, thank you so much.
You're welcome.
This is a great, incredible conversation. It reminds me of a conversation we had with Marshall Allen about not paying the first bill. There was a book that he wrote. Sadly, he has passed away since he did that episode. But this was just a great conversation. It's a shame that you had to go through it, but somehow I feel like God's using you. This suffering that you've been going through, it happened to the right person. She's going to do something.
There's so many opportunities to do good here. And, at the end of the day, much to be grateful for. I wasn't hurt worse, certainly. And because I wasn't hurt worse, it meant that this young woman that honestly made a mistake. She wasn't on her phone. She wasn't under the influence of anything. She made an honest mistake. This was an accident through and through, in the purest definition of it. She and her son also are going to be okay. And that is something to be grateful for. And incidentally, the intersection where my accident happened, over the past 10 years, this has been a very problematic intersection, nearly 60 accidents there. There were one or two fatalities at the intersection since my accident in February. And the Colorado Department of Transportation has closed that intersection. And they are doing a safety assessment and figuring out how to improve safety overall there. And those are both really, really good things. So lots to be grateful for.
Thank you so much, Dr. Hughes.
You're welcome. Have a great rest of your day.
Great. Thank you.
What are your thoughts on physician as patient navigating medical emergencies? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.